Just waiting for a few people. Welcome back, everybody. I think people are slowly joining. Sometimes the link takes a little bit of time. Thank you again for taking the time to join me on your Wednesday evening for our weekly webinar. The past two webinars have been about full mouth rehabilitation, as are this one and the next one. So the 4-part series. This is part 3. I'll just go over, sorry for people that have heard it all before, but just going some housekeeping, just going over some things that we're running at the moment, plus our dentist webpage. And as soon as we've got through some of that, we will start the webinar. Okay, without further ado, let's have a look. Okay. So just as I said last time, sorry for those of you that have heard it before, but this is basically, there's an implant boot camp coming up on the 5th and 6th of February next year. And we seem to always have this. Let's just get out of this for a second. Problems again with our Zoom link. I am just going to step out and see if I can step back in again. Excuse me for a minute. Okay, let's try again, shall we? Bear with me just one moment. Seems to be a weekly occurrence now. Okay, let's go back to where we were. Okay, so there's a boot camp on the 5th and 6th of February. Please contact us at hello.drbobbychhoker.com.au. And you can, it's the same attendance price for one person as it is for two, so the opportunity to bring a friend, and half the price is $595 for one or $595 for two. You can either contact us directly on 0280709010 or via our website, our email, hello@drbobbychhoker.com.au. We also have a dentist section on our website, so please visit. There's up and coming things there. We will be uploading all the webinars as well to a few places, and people will just need to get access to that by contacting us. But let's try again and see if we can start the webinar. Okay. So we've been through that. One of the things that people constantly talk about is the controversy of 4 implants and immediate loading, posterior tilted, anteriors with axial loading, but the posteriors don't, and they're loaded within 48 hours, and then followed up in this particular study. This is the Franchetti study. It measured bone loss and found no loss of the tilted versus axial, maxillar, and mandibular implants. There's no fracture. This is another Marlowe study. No fracture components, assesses forces from non-balanced occlusional parafunction causing screw loosening only. And this is one of the major advantages of having multi-units, because the forces are transmitted to the multi-unit as opposed to being transmitted to the implants themselves. So the worst that you can actually get is that the bridge or the prosthesis becomes loose. I mean, it's still not ideal, but it's a lot better than the forces being transmitted to the implants, causing bone loss and loss of the implants. The Crackmino et al. Is quite a well-known study. It's called cross-arch stabilization, minimizing micromotion, because the main thing is that how can you immediately load these implants all the way across the arch? As I said, full mouth rehabilitation implant dentistry is completely a league different away from regular implant dentistry and requires some completely different thinking and some principles. That's why I encourage people, if they want to get into this or even learn more about it, if you're at a beginning stage, you're just excited to see what goes on or where you want to go to. Your objective, or we're happy, as I said before, for you to come in. You just need to organize that by contacting us. You can come and assist, you can come and observe. We just need to know in advance so we can book you in to a procedure, and we do quite a few of these a week. So we would just need to get the patient's consent, obviously, for you to be an observer. There was worry that in this study, the crack we know that there'd be high stress concentration, bending forces, great moments. They found no difference within the implant that tilted versus the axial because of the cross-arch stabilization, and that's why that's very important. You need to have a passively fitting prosthesis, and we go to great lengths to make sure of that, using modern technology and a number of things that we do to make it absolutely precise. For those of you that attended last week, the older technique of having a denture, making holes in denture using cylinders, I prefer not to use anymore, because there's much better ways of doing it, far more accurate, and you end up with having fewer complications. The rigid bar was used to connect the implants and stop them from moving. Only micro motion that is negligible and does not affect osseointegration. So you're not really getting that micro motion and the formation of granulation tissue and preventing osseointegration. So that's why that's important, and that sort of answers, those two things. Why the immediate loading, how's that possible, and also, people are constantly worried about those tilted implants. So the advantages of tilting are the reduction cantilever through tilting, because if you have a straight implant, the point at which that implant to the prosthesis ends. So if you say you're placing a straight implant and you can only place it at, say, the first premolar, let's just say we're doing the upper, and you're restoring to the first molar, you've got if it's midway through the first premolar, you've got 2.5 teeth cantilever. And ideally, you don't want to exceed 14 millimeters. You want to try and stay below that. You want to try and have the smallest cantilever you can. Otherwise, the moments and the forces on those can be excessive. The longer implant places increase implant to bone contact and hence gain primary stability. A lot of these cases, the traditional ways to use bicortical fixation, which we went through last time. If you can get the required torque, 35 Newton centimeters, which you need in each and every implant. You can't have 3 and the 4th one doesn't, and it's nearly there. If that's the case, you have to go to denture, delayed loading. I don't use bicortical fixation, because if you can now get that torque without doing that, I have in my mind a contingency plan as to the way that I do things, and take with a pinch of salt. It's all personal, depending on what you want to do, but I base it on very strong foundation and principles, evidence-based. And it also allows me the liberty, should something happen to the implant, to be able to remove that implant and place it with a longer or wider one, because I have the bone. But if I use all that up, I then need to reposition the implant or graft or delay and come back, and that significantly lengthens the treatment plan. More importantly, not really for us, it really doesn't matter about lengthening it. You shouldn't be in a rush to do these things. It's more for the patient, because you can't really base a bridge on 3 implants. So that means they then have to wear a denture. If they're anticipating having a bridge, managing expectations. If you have to allow that osteotomy to graft, and you can't place a graft or place a new implant, that graft will need to then take 6 months to mature, after which you place the implant, and then it's up to you whether you take the risk of immediate loading then, or play safe and keep them in the denture for another 3 months until the implant is integrated, and then load or go to final prosthesis. So the patient could end up being in the denture for an extra 9 months. The residual bone better than grafting. Okay, bone grafting requirement is diminished, although we do use bone that we use alveolectomy or collect and we treat it in a very particular way, and then we do use that in certain areas for specific reasons. Bigger sort of topic, more on the bone grafting stroke full mouth rehabilitation theory. Again, come in, have a look, see what we do. We do it in a lot of cases, so you're likely to come in for one of those cases to see where we do it and why we do it. And if people come in, I usually talk through what's going through my head and why we're doing things, so that you can learn quite a bit. And you avoid anatomical structures like the ventral nerve and the ID nerve and sinuses. This is probably one of the major advantages of tilting those implants. Evidence-based use of tilted implants versus grafting procedures, uses of 4 implants, and immediate loading. Okay, there's a systematic review of survival rates for implants based on the grafted maxillary sinus. Overall survival rate of 39 studies was 91.49%, which is quite good. And the cohort, the database, was nearly 7,000 implants and placed over 2,000 subjects. And the follow-up was between 12 and 75 months. Implant survival rate was still 87.7 with grafts of 100% autogenous bone and 94.88 when combining autogenous bone with various bone substitutes. And that's what we tend to do. There are particular types of graft that you use with autogenous based on the situation. It's not a one-set formula quick fix. Again, this goes very much into the domain of grafting procedures. So, you would need to come and see me or come and have a look, so you can have to see why we're doing those. It's almost a huge topic in itself. The survival rate for implants having smooth, rough surfaces was 85.64 and 95.98 respectively. And the sort of survival rates for simultaneous delayed procedures of 92.17 and 92.93 respectively. So when implants are placed in grafted maxillary sinuses, the performance of rough implants is superior to that of smooth implants. Bone substitutes are as effective as autogenous bone when used alone or in combination with autogenous bone. You need to treat both of them in a particular way and combine them in a certain way, and then place them in a certain way, and actually a suture and the type of membrane that you use each one is different, including the suture. Okay, 10-year survival rates of prosthesis 4 or 6 implants. This is a Brannemark study. And they found that, rehabilitated by means of fixed prosthesis, either 4 or 6 screw-shaped titanium implants. And they calculate the survival rates for both prosthesis and individual implants. And this is a 10-year follow-up. It was considered the only patients that were considered. The implant lengths, 90% were 10 or 90% 7 millimeter, and they were all inserted after pre-tapping in the mandible. And said, although a tendency existed for an increased failure rate in patients with 4 implants, the survival rate for both individual implants prosthesis was the same in groups at the end of the 10-year observation. It is marginal, but it also depends on the follow-up and aftercare and maintenance. And that's why the pre-assessment of whether the patient can look after this and the post-maintenance, as well as the reinforcement of aftercare, is very important. And it's not fit and forget, because if a patient comes back and you haven't sort of reinforced that, taught them how to do it, check that on a regular basis, it's your responsibility to call those patients back and check them. You can't just let them out into the ether, even if they belong to another dentist. That's fine. Never really go about or poaching a patient or anything else, but you can specifically see them for your implants. You can place them. That's why they say, like, I see these cases where they've got sort of 8 to 10 implants top, and there's the tendency of somebody should store as many implants as possible in full edentulation should be seriously questioned. And I agree with that. So this is an all-on-4, as Noble seems to call it. It's a medium function concept of completely edentulous maxillary, clinical report on the medium 3 years and long-term 5-year outcomes. This is a Palomar study with Miguel Aguirre Nobre. The longitudinal study of the survival of all and 4 implants in the mandible with up to 10 years of follow-up. Immediate function implants have become accepted alternative. And there's the protocols in dental manuals are basically documented at high success rates, and that's why they've created this sort of surgical and prosthetic protocol, which basically I've been through most of in the last 3 seminars, but we will be going into today as well. And they've conducted a long-term study on this and finding that they're highly successful. Total of 21 implants failed with 13 patients, giving cumulative related implant rate success of 94.8% and 98.1%. Respectively at 5 years and nearly 94 and 95% at 10 years. And the prosthesis survival was 99.2 up to 10-year follow-up, and that's pretty good. If people sort of look at the survival rates of other types of dental treatment, you'll find that you'll be hard pushed to find survival rates or success rates rather as high as this. So single tooth assessment versus full mouth rehabilitation, and I just wanted you to have a bit of a comparison. So we've covered this in one of the other webinars, I forget which one, but with a single tooth, let's just say it's immediate, we sort of use we have to look at each individual tooth, even when we're doing a full mouth rehabilitation, and put it into sort of one of these categories: good or fair prognosis, a poor prognosis, a questionable prognosis, or a hopeless prognosis. And you have to say why you're putting them into these categories. The reason being is that if you're taking out teeth electively, which may not be healthy but may have a guarded, there's another section that I would put in there between poor and fair prognosis, is a guarded prognosis where they need to be monitored and they need some treatment to basically keep them in the mouth to get them to a fair prognosis. And if they can very easily go the other way too and go to a poor prognosis. You need to be able to justify that. If you come back and you've taken out all the patient's teeth, you need to make sure why you're doing each individual tooth, because you are responsible for that. And part of the note writing part we do within also within our boot camp, we go through how the basic format of your notes should be. It's not copy and paste, it's templates that you need to populate, because it's sort of frowned upon for you to be using copy and paste, even if you're writing the same thing again and again. And you need to personalize it to the patient. And within this, we write things in a certain way, and we have a set of templates, great English there, sorry, a set of templates for each appointment for a full mouth rehabilitation or even a single implant. And they have quite a few categories that allow us to cover every aspect, and it also allows us to cover all risks and complications because the patient's fully aware, and then we use that as part of our consent. And remember, you have to remember that consent, informed consent, is a process, not a document. Again, at the boot camp, we cover this in quite a bit of detail with some examples, and that will get people into the flow of writing their own ones. And we give you those, we give you the actual consent that I use, but also, we give it to you with a few examples so that you can then use those for cases that you may have, sort of 3 or 4 common examples. But we work through some cases from start to finish so you can get a grasp of, the treatment planning, the planning of the drilling protocol and how we're going to restore it, consent as well, and then also some complications, some digital planning. And at that course, I will be doing a demonstration of the drilling protocol. So we'll take a case I don't know off the top of my head, but I think it's a single anterior, single posterior short space, which is what most people would start off with, or if you're placing implants, people want to revisit and make sure they're doing the right thing. But that's all at the boot camp, so get yourself there. Okay, this is sort of an example of like an aesthetic risk calculator. I think there is a version by TI. This one's by our professor, who is the academic head on our certification diploma and master's degree. And he basically, along with the university, accredited. So you have an accredited qualification, which stands as and is recognized internationally, as opposed to going on a course where you're putting in implants and doing all this other stuff, but it's not valid unless it's been it's of a certain standard. And this is all evidence-based. Stuart Harding, Professor Stuart Harding's been doing this for a very, very long time. I think it's probably, coming up to 30+ years, and been teaching internationally. He has centers all over England and all over the world now, including South Africa, Greece, to name a few, in Dubai and the Arab Emirates as well. So I think he pretty much knows what he knows about it. He's a bit of authority on it. For example, this is a score index, and you're taking into account things like medical status, smoking habits, smile line, history of the site, and reason for tooth loss. That's why it's important, whether it's trauma, infection, failed root canal fitting, or split root. This patient's aesthetic expectation, which I will say is going to be high. They're your general factors. The dental factors include infection at the implant site, whether that decides whether you're going to immediately place or not. We've been over why in the past, the width of the dental span, tooth position and regularity, restorative status of the neighboring teeth, very also important, and the bioform, and they form your dental factors. The soft tissue factors, just as important, are your biotype, because things react differently and the healing is different, and you have to treat those tissues with respect. Potting depths of adjacent teeth and or the tooth to be replaced, so you need to make sure you're addressing the peri element of it. The height of the existing papillae and evenness of the FGM, so you want to make sure that you're able to reproduce that. If you've got a very sharp tall papilla in a biotype 1, that's going to suddenly become a complex case, and there are certain things you need to do to make sure you're trying to mimic, if not trying to preserve, those areas. The soft tissue health and the amount of gingival recession, and also with the type of biotype, you'll pretty much know from either or which one it is. And that gives you your soft tissue factors. And then hard tissue factors is a condition of the residual alveolar ridge of the site and the bone zone, the radius around it, but also include that I would look at bone quantity and bone quality, whether it's D1, D2, D3, or D4. And this gives you a score between 1, 2, and 3, and you're scoring those of them. And that gives you basically an outcome that you can then discuss with the patient, keeps you within your prescribing profile and your experience, and keeps you safe, and also lets you know, whether or not you should be treating that case. Having said that, there are cases that may be, a high score, and with the use of a referral and bone grafting or whatever it may be, you can then convert that case into a low score, which you can then take on. So it doesn't mean you have to basically make the case completely. It may require some pre-treatment before it becomes something that's treatable by you based on your scope of practice and your experience. But ultimately puts into predictable soft tissue aesthetic outcome, acceptable outcome where there's some reduction in the heights of the papillae and unevenness of the gingival margin, and then the unpredictable, and they're to be avoided. You can consider conventional, but you shouldn't gear patients towards that. You want to give them the option. And if they decide they still want to carry with implant treatment, then as I said, you may need to involve somebody that makes that case simple for you, or refer it completely and learn from it. Okay, we have a similar sort of thing we use for mouth rehabilitation. This is the older one. We have a quite an updated one, which has become quite different. I found that this one's become a little bit out of date, but I just wanted to give you the basics of like where we started, where we were thinking. The more complex one we use in surgery and forms part of our notes, consent, and everything else, and our planning. But I think it's like a lot longer. It's about twice as long, and some of those things we've actually changed because we found that they can be misleading. But you want to see the patient's motivation. Is it pain, infection, the appearance, minimized dental visits, chewing function, all of the above? The particularly important things that you need to have a look are at whether they're on, if they have osteoporosis and they're on bisphosphonate therapy, and what type of bisphosphonate therapy. Is it oral? Is it, do they have an injection yearly, etc.? Whether they're diabetic, type of diabetes, their blood sugar levels, cardiovascular disease, what type of disease, whether that affects it, bleeding, if they're breathing problems, or if they're immunocompromised. There are a couple of things that we've added to that as well that occur and quite often can be missed. Which arch you're treating, whether it's dentate, partial dentate, edentulous, whether it's caries or periodontitis, which you usually need to be addressed in some form if the teeth are coming up, then temporization, coming out, sorry. The implant site infection, again, like the single tooth, and the bone volume and bone density. Also, you need to see where the sinuses are. Again, we've adapted this a little bit. They put some extra bits in there because sinus wall angle and just the position are not sufficient for the planning. And at that time, we do that, and we had the same with the dental nerve position with normal anterior, posterior, which will tell you where your angled implants will go, and therefore will tell you the emergence of those implants, and therefore will affect the cantilever and your prosthetics. The lip line, as we discussed last time, while that's important, how you plan in full mouth rehabilitation, the mouth opening. Opposing teeth implants and gingival biotype, which we've discussed. Mouth opening, very important. Sometimes you have a patient and you're planning all of this and you check it, you can barely get a mirror in there. I don't know how you get the drills and everything else you need to get there, and also the visibility of that site. In certain cases like that, we've actually gone to GA, where it's much easier to do it under that basis with a mouth prop and everything else. But that's too much for a patient to take under sedation, definitely not with just local anesthesia. The vertical dimension, whether they have power function, the skeletal relationship, are they a smoker? Have you talked about smoking? Their general medical status, oral hygiene, that also forms part of our build-up of the case, because we want to make sure if they haven't got satisfactory oral hygiene, that we need to get them there prior to surgery. And there needs to be a decent enough time between your initial consultation and the surgery. A few weeks is not enough. You're talking a few months, because you have to show that you have actually assessed the patient's oral hygiene adequately, and the prosthesis you're going to put in their mouth they're going to be able to take care of. Otherwise, you not only have done them a disservice, but you're going to end up landing yourself in hot water. And their adaptability. Now, how do we measure that? It's really character based, and you can see pain and other thresholds going from there. And then this is the bottom part that's completely changed. Where the implant nets and abutments, those don't actually match up with the implants I use now, which are Straumann implants. And we've added things to what we actually need as a checklist. Some of those are still there, CT scans. We don't take an OPG anymore. I use PAs if I need them, scans, and that's become quite complex now as well, because we assess the occlusion as well prior to placement and plan all of that, photographs still, and a few other things that are involved as well. Okay, so step-by-step guide. This is sort of a longer part. We're going to start in this, and I will carry on with this afterwards. Okay, so the immediate load should be performed by a qualified medical professional. We've already discussed that. I'm not going to go into that. This loading protocol is based on the Brandemark originally loading protocol, which still stands and is used today. There have been some modifications. This is the basics. I'm going to go to the basics so grasp, but we'll go into the other parts, just like this one slide I could probably talk about for at least an hour when we do the 4-day full mouth rehabilitation full course with hands-on and everything else, and an actual patient. We then go into that much detail. There's pretty much 2 days worth of full lecturing, a 3rd day of patient live and everything else, and then the following day is the prosthetics, and also the upgrades into hybrid. So it's quite a large subject, and it used to be an 8-day course, and we managed to condense it into 6 and then 4 days, but the 4 days are a bit longer. What they require, they're multiple helpless teeth, fully edentulous. If the lesions are endodontic and are present, avoid immediate placement. Consider extraction, socket preservation. Minerals is basically one of the bone grafts now. BioHorizons supplied, that's why I suggested it. It needs TGA. The reason that it's quite popular is it contains bone morphogenic proteins. The BMPs, which have been documented and scientifically proven to greatly enhance the success rate of bone grafting, and that's one way of doing something. There are other ways of doing it. I don't agree totally with endodontic lesions. It depends. Do we sort of deny somebody have full mouth rehabilitation because of endodontic lesions? No. If we can clear the site well, and we can avoid those APCs with our implants, and we've cleaned that up really well, depending on the situation of the patient, it's not as easy as that. We may evaluate the medical history, and assess the anatomy. In the mandibular treatment, you have to assess the height of the ridge between the two mental foramina. And you need at least 12 millimeters height. That has changed a little bit with the advent of digital technology, because things can be done in a different way. The same patients with larger frame may need 14 millimeters. So it says right. Ideally, 10 to 12 millimeters of implant surface should be in bone. If an implant with a laser lock is being used, that's just another BioHorizon type of implant. That would be probably the bare minimum I would use as a vertical implant. Sometimes in the anterior area where we could place vertical implants, I may actually tilt the implants in the opposite direction to get bone implant surface contact, and again use tilted multi-units to upright those implants, and at least 5 millimeters with ridge width. I think that it should be more than that. I don't think you should place implants to 5 millimeter ridge, because ultimately the implants that we use for full mouth rehabilitation tend to be 3.8 to 4 millimeters. I use the 4 mil Straumann's. And I recommend that you have 2 millimeters of bone around the implant, whether it's a single implant or for full mouth rehabilitation. You need to assess the bone posterior to the canine area for possible implant placement. Okay, for the maxillary treatment, pretty much the same at the front, but you just need to assess that going back, because you need to know where you're going to be placing those tilted and straight implants. And if there's insufficient vertical sinus augmentation may be considered, and delayed loading is recommended. The reason they say this is because it's not just that height there. If you have smile line, and we know we've discussed this before, you want to be 5 millimeters higher than the smile line, ideally higher than the highest sort of smiling point. Sometimes that's not all possible. You also want to have enough bone beyond there and the nose to be able to place the implants. And if you don't, then you will need to consider a slightly unconventional way of placing implants, probably more straight and axial. You can tilt some of them, but you'll be going more posteriorly. If I was placing a 10 mil implant anteriorly, I would not want to sort of base it in that manner. I'd want to have better contact. Sometimes I would just place 6 to get the anterior posterior spread, not because, as we've discussed before, 6 is better. Assessment of the gingival exposure, and again, we've discussed this before. That's basically seeing, as I said, 5 millimeters above the smile line is where you want to be. You can consider an alveoplasty to hide gingival at full smile, because sometimes you have that situation where, as I discussed, where the smile line is high and you leave very little bone beyond that to be placing implants. So, that is another way of doing it. And you also need to, this is really important, to evaluate for appropriate lip support and nasolabial angle. And this is missed a lot. And you get the stretching of the lips. There is a particular way of doing that. It's a very simple way of doing it, but it does need to be assessed. And so, the tip is that the contour, the process use is necessary to achieve an appropriate aesthetic outcome. Now, that's such a vague comment. What does that mean? Nothing. It's pointing in the right direction, but there are markers that you need to use to check that you're not encroaching on the neutral zone and the biological zone, and some of these taken from denture prosthodontics. Okay, the biomechanics. You need to determine the patient's arch shape. It's because ultimately you want a decent anterior, posterior, or AP spread. And you want to limit that cantilever. Limits the AP spread if there is sufficient posterior bone over the inferior alveolar nerve, because then what you'll do is you'll place additional implants, as you can see in the diagram below. If there is limited vertical height in the posterior, consider placing a 7.5 or 9 mm laser lock implant. In extreme cases, consider placing a laser lock implant supracrustally. I wouldn't recommend this. If you need to do this, and this should be assessed prior to your surgery, usually there's sufficient bone posteriorly to place 2 vertical or axial implants. And if not, as strange as it may be, we're concentrating on the front. You can either have a shorter prosthesis, and you need to discuss that with the patient, because a shortened dental arch, premolar to premolar, may suffice, and the patient's happy with that. Alternatively, we could consider posterior grafting so that you can actually get enough bone to be placed in those additional implants, and they're not all gathered towards the front. As I said before, it's like having all the legs of a table on one side. And then oral hygiene we have discussed. So occlusive considerations, there's a lot more than this, and we go through occlusion again on our program. I actually discuss it for single teeth and short spaces, and it's not much different from doing full mouth rehabilitation. So obviously with the full mouth rehabilitation, there are certain other things that you have to ensure, because you're not relying on the existing occlusion or where you're going to restore to. You assess for balanced and lingualized occlusion. If the teeth are already set in lingualized occlusion, proceed with further assessment of existing denture. Check the existing denture for excessive wear, and consider modifying the dentity if they're fully anatomic. Ensure the denture maintains a proper vertical dimension of VDO. We can now do this digitally. This also plays into the anterior aesthetics in terms of the fullness and the philtrum, and the biological zone, as well as a neutral space. And then the maxillary denture aesthetics, show appropriate lip support, nasal angle, just discussed, and tooth display between 0 to 3 millimeters for older aged men, 2 to 6 for older to middle-aged women. I don't really follow this protocol. I tend to base it individually on the patient. Some patients naturally show lower teeth more than they show upper teeth. Some patients have longer looking teeth naturally. A lot of the patients want to go back to the style of teeth they had because they feel they are natural. Not all of them, some of them want a complete change. And that's why we have sort of set processes and trines, and we print trine prosthesis for them to dry. But some patients have a longer tooth and show more than that. And patients who want to restore, pretty much they will say, well, you know, I want them to look like when they did when I was 21 and they were all straight, etc., if they were straight. So, you know, all of that needs to be taken into consideration as well. You need to check for phonetics, the V sound inside, so they just touch dry wet line of the lower lip, basically the vermilion border. That's important. Again, with the F sounds, you need to inform patients that they may have changes in speeches, and some patients may have a permanent change in speech. And most of them adapt over it, but you need to be aware of and clearly pronouncing the S sounds. So you should get them to count for 60 to 70. The old denture Mississippi is another one that people use. Also, you need to be aware that, you know, it's having that freeway space in there as well. You need to be careful that patients, especially where you've got zirconia prosthesis or something more rigid or less absorbing than impact or high impact acrylic as a hybrid or even in the provisional, sometimes you can get some clicking sounds, and patients aren't too happy about that if they're constantly talking and just clicking all the time. And it can pose problems. Sometimes people have very little space for that to happen. In certain cases, you know, I have had a case where we've cleared that space and they, you know, we put them into the acrylic prosthesis and we've actually evaluated and they're not clicking at all. And we have the identical zirconia prosthesis and they're clicking. And I often found that they've almost like, because they know it's going to click or they get the odd click, they almost make it click, almost sort of becomes habit-like. You know, they're almost like testing it out, trying it out, pushing it, whereas they wouldn't with the other prosthesis. Prepare a surgical guide. If you're placing, that you can get stat guides, other guides. We evaluate guide techniques and everything all the time for myself, my own practice, and for the university. And we have sort of the biggest guys and ladies in this field who basically sort of give us lots of direction of how it's become more and more and more accurate. But I'm still yet to see a totally accurate stackable guide that I think you can just use blindly. Okay, remember they're guides. The clue is in their name. They're only meant to be a guide. You're meant to be assessing it. You're in control. I'm not the biggest fan of using these. There are certain guiding elements that I use within the surgery, certain instruments I use to help me get the angles I need to get the apex of the implant and to a certain point to make sure alignment I have, anterior, posterior positioning, and also to make sure the facet of the implant is and the fixed connection is at the right side of the implant so that the multi-units then connect to give us a vertical position, not an angled one, particularly for the posterior implants. Marking the midline, we still mark, I still use it as a foolproof sort of loop back mechanism, because you will get complacent when these become sort of second nature to you, and that's when things can go wrong. So we just go back to almost basic principles as if we were doing one for the first time and do that, and it allows us to quick check things. Consider a paralleling tool. I've never used one. There's various ones out there. And now you can use guides rather than the paralleling tool if you are going to go down that path. Plan the distal implants in the anterior region of the mandible, 7 millimeters anterior to mental foramen. The reason that they tend to do is not just for the spread, it's mainly for the mental nerve, because the loop is 5 to 6 millimeters from the mental foramen. So placing it at 7, you'll mill away from it, and that's not the way that I'd approach it. And the best way to do this is evaluate the CPCT and map your nerve. If you have any planning software, I use Co-Diagnostics, great software, I really like it, and allows me to map the nerve very accurately. And that even if I'm not, using a guide or planning, it's designed to actually for planning and then creating a guide, whether you're going to print it yourself or send it to a lab. If you have that facility, we tend to print our own guides. Sometimes we'll send off a plan to print it if it's just complex, take it 2 hours time. But you need to map that anterior loop, because if you don't map it, placing it 7 millimeters blindly, I've seen loops that are bigger than that, smaller than that. And even let's say every loop was 5 to 6 millimeters, I wouldn't be placing an implant 7 millimeters anteriorly. Plan the anterior implants halfway between the distal implants and the midline. Yes, that is true. That's you trying to get your anterior posterior spread. That's where I want to take it to this time. I want to go, this next part involves a little bit of a bigger conversation too. They're not just the simple slides as they're shown there. There are certain things that I need to add to that so that I make sure that you're getting the whole picture. I hope everybody has enjoyed today's webinar. We are trying to keep these down to sort of 45-50 minutes, so that when in the past I have unfortunately, and I apologize, waffled on for way over an hour. I'm sure everybody's attention span after that diminishes, and the last thing you need is me going on for 4 hours and hours on a Wednesday evening. I'm just going to stop sharing my screen for the moment. If there are any questions, now is the time to ask. I'm happy to go over anything that pops up. If you have anything you want to ask and you don't want to be on a platform where everybody's observing, sometimes that's easier and a bit more comfortable, please contact me. I'm happy to speak to anyone. Come and say hi. We're always open to people to come and have a chat. If you're embarking on an implant career, you've started and you feel you haven't got a real set program and a proper linear progression and a career pathway, come and talk to us. That's what we do. We don't charge for people coming to practice and having a chat, and there's some exciting things going on as I discussed. Get yourselves on the boot camp. Like and share us on Instagram and Facebook. We're trying to build a community, and that was what will basically allow us to keep doing these, because if we have the numbers, that's what we need. I hope everybody's enjoyed part 3. We'll be back part 4. We will talk about the rest of the actual execution of the full mouth rehabilitation. I hope you all stay safe, and I look forward to speaking to you next week. Take care, and bye-bye now.